Hi there, folks. This is Dr. Ellenburg. Welcome to our medical show here on Fox News Talk 1020 AM. We're also find us on 95.5 FM. Also find us online at foxnewskon.com. That's foxnewskon.com. Listen to us live streaming on the web. You got questions about your health? This is a medical show. We do encourage your phone calls here. It's 522-1020. That's 522-1020. Some reminders, how do you find me during the week? You will find me at the Ellenburg Center for Natural Medicine. Our phone number there is 563-2366. Our website address is www.drellenburg.com, and that's DR and Ellenburg with a U.com. List of our services. We also have a list of websites. You can learn more about things out in the world or in your own home that might cause disease and sickness. We have other sites so you can learn more about a variety of topics, including vitamin D. And we do, of course, have archived radio shows on our website. Please check us out at drellenburg.com. And a few reminders here during the month. Each month I do typically go to Palmer and Kenai monthly. And please call our office at 563-2366 for times and dates. Okay, well, it's going to be an interesting show today. As always, it's always fun to deal with technology between the MacBook email to my iPad. Didn't work. So I just found out right now today. It's been a busy day. Been back at work. So I was down at a conference. So we're going to talk about a gastrointestinal conference I was at last week in Las Vegas. I had a couple of topics from that I wanted to bring up anyways, and my memory isn't that bad, so we'll have things discussed there. This will be a wonderful day to have some phone calls with questions about your health. Again, 522-1020. It's 522-1020. Questions about your health or questions about our topics. So gastrointestinal disease will be our topic, our major topic of the day, and I will filter through my brain as we go along here to figure out what else I had on the agenda. Usually I have about 6 things I talk about. And so let's get into that. And I won't be able to pull off the top of my head the listing for the research that it comes from, but believe me, it did. So on this show, I typically will tell you where things come from if you're curious to read more or learn more about the full article that was available online. One of the first topics that I was going to talk about today, of course, is cancer. And I mentioned last week that the fact that I do see cancer patients and the fact that cancer is such more prevalent today than it ever has been in our country and in the world, I think it's important to bring up topics frequently about cancer and various treatments that may be available, things that increase your chances of getting cancer, and what is new information out there in the cancer world. And one interesting area that you wouldn't really hear a whole lot about unless you've been a cancer patient or had somebody who was a cancer patient in your family or your provider is that a lot of cancer patients tend to have very thick blood. Okay, that's just it's an easier term for also calling a very medical term called hypercoagulation or hypercoagulability. That means their cancer patients' blood tends to be thicker than the rest and clots easy. And we tend to see that a lot more in patients who have metastatic disease. That means cancer spread out of the primary site. So if they had breast cancer, that was stage 3 or stage 4, or say they had colon cancer, stage 3 or stage 4. A lot of those patients, not all patients, but a lot of them tend to have thicker blood. And the question that a lot of patients have asked over the years, and we have discussion in the office, is, well, why is this? And there's certainly things involved with tumor secretion in the body that is causing the blood to thicken up. One of the questions I've always had is, what is the benefit for cancer, if there is any, for cancer itself to grow faster in someone if their blood is thicker? And there's been a wonderful book that I had a chance to just dig into a little bit. And I'm not going to recommend it for the sense of anybody out there who, unless you've got a good background on biochemistry, it can be a very confusing book, although he does explain about biochemistry in detail. But a new book written by Thomas, I'm going to say Seyfried, Seyfried was his name. He is a biochemist and a geneticist, someone who studies genetics. And the book is entitled Cancer Metabolism. And he goes into a great detail in the book on describing what takes place at the level of a tumor cell, as far as how are they creating energy. And I'm going to get back to the hypercoagulation in a minute with the study that came out that was showing that cancer patients are at increased risk of stroke, or if you've had cancer and you're now in remission and you've been better for years, a lot of those patients are still at an increased risk of stroke because their blood clots easy or has hypercoagulation. But one point that I try and bring up frequently about cancer, as you know on the show, is talking about what type of diet should people be considering if you're diagnosed with cancer or if you prevent cancer. And the biggest thing is a diet low in sugar, okay? And the main fuel source in the body for tumors is glucose, a type of sugar found in the body. And where things become different is how tumor cells create energy to get bigger and spread in comparison to a normal human cell. And one thing to remember is that a tumor cell was once a normal human cell, except it now lacks something called programmed cell death, also known as apoptosis. And apoptosis, when the cell doesn't die, cells need a lot more bioavailability of agents around them. In this case, energy sources to create more energy. And every cell, even tumor cells, use mitochondria that they have, because kind of like the battery of a normal cell, even the tumor cells, to create energy. And the process has a long name called oxidative phosphorylation or electron transport chain, with the end product being a certain number of ATP being created to run the energy processes of the normal human cell and even the tumor cell. Now, where things are different in a tumor cell is that the tumor cell is going to use a process called fermentation, where basically or glycolysis. They're taking glycogen as a storage form of glucose and breaking it down into glucose and using that. And this process also creates a fair amount of lactic acid, which is something that happens in normal human cells and muscle cells. If you exercise a lot, you produce a fair amount of lactic acid because your muscle cells are using a fair amount of glucose. And when that is being broken down, an end product can be lactic acid. And so in a tumor cell, you have a major buildup of lactic acid. Then parts that can be recycled back in for the cell to use it again, tumor cells that is, to make more ATP, to make more energy, to run the process of the cell and help create more of them, and the end product being the case. So it's a major shift in what tumors are eating versus normal human cells. So when we hear a patient, I heard it today this morning, that patient I hadn't seen for some time, and they came in and we were talking about, hey, how have you been? They've been down low 48, receiving treatment. And we got talking about the type of diet that they've been doing, and they've been following a very, very low sugar diet, eating a diet that will create more of an alkaline urine in the body. You can measure pH in the body real well through the urine. And so their diet is focused on creating alkalinity in their body. The diet is also set on low sugar. And they were surprised that some of the cancer patients they'd seen in a certain place in lower 48 where they were receiving treatment, or these people were eating milkshakes and just eating what they wanted to, and eating candy bar or whatever, or a soda pop, just things that in my mind, as a naturopath doctor, it just makes no sense for a cancer patient to ever eat. The only caveat I would say that is if someone has been diagnosed, they're not far from leaving the planet and they want to have food they want to eat, well, then go for it. But most people that I'm seeing are ready to stick around and are ready to make any change that will help them live longer and help them fight their cancer much better. And so diet there comes into play. And again, the important piece being, why would you want to provide the body with more sugar than what it needs and providing exactly the fuel source that tumor cells are using to create and grow and get bigger, right? So it makes a lot of sense not to be doing that. And I think what might be interesting, getting back to the study we're talking about, where people with cancer who have had cancer, the study was done in Germany, found that a lot of patients had still thick blood, in this case, or hypocoagulation of blood. And so getting back to the original question I'm asking is, why would they be a good thing for cancer? Well, maybe somehow it helps decrease the oxygenation or the environment around tumors in the body. And we do know that tumors tend to work in an environment that's lower in oxygen, yet they can still work in an environment that's high in oxygen. It can go either way for them. It doesn't matter for them. Where if we were using oxygen, if it was higher oxygenation, is way better for overall normal human cells. So they can work in an environment like that, but maybe if they're lower in oxygen, it might actually increase the ability for them to make more energy overall because glucose is being used. So maybe somehow in the process, having thicker blood slows down nutrient support to the body in some form or fashion. It probably slows down the immune system to some degree in the blood directly. That might be trying to directly fight and kill tumor cells. This is one hypothesis. That means one idea, because we don't know for sure why that happens, but it does. And it's something that to be aware of in therapies. And We even have there's natural blood thinners that exist out there in the market. Things like what's called nattokinase, which is a form of a fermented soy product called natto or nattokinase. Other product also known as lumbrokinase. It's going to sound like this is a Chinese herbal medicine class, but lumbrokinase comes from earthworms and is also used as a natural blood thinner for a lot of patients. And even some medical doctors in DOs in different states, I've seen them actually have patients on those products versus taking something like warfarin or even a newer drug called Pradaxa, which also thin your blood out. Warfarin also known as Coumadin, and many, many patients are on Coumadin, more so because of the fact that they may have a history of a cardiovascular problem, like one, for example, is atrial fibrillation, with the atria in your heart, you have a left and a right one, and maybe either side tend to flutter, and when that happens, it can cause turbulence, to be a good word to use, and blood flow, and that can lead to blood clots, and that can lead to strokes. Okay, so that's why they're using that a lot in those patients. Anybody who's had a heart attack, a lot of times they may be on Coumadin for a long time, or some other blood thinner, or those who've had a stroke. So there are different thinners being used, but there are some natural ones that exist out there. But there's a lot of things that come into play when looking at cancer patients in general, and what you can do for your own health. And I highly recommend, if you have cancer or you've been in remission, or if you know somebody has cancer, really pay attention to what type of diet they're doing and what you're doing. Because if you continue a diet that you were doing when you had cancer that wasn't low in sugar and was just whatever you wanted to eat, you're increasing your risk of developing cancer again. And as we do know, cancer is definitely on the uprise in this country. It's not going down, no matter what kind of numbers you might see on the mainstream media. They're not true, okay? I mean, there's charts that show these sort of things online that exist, demonstrating that death rate from cancer hasn't changed in 60 years. And there's more people living on the planet, right? So death rate's the same, larger populations. So, and that's not going down is a problem. So we need to find a lot of different ways to try and treat that. And one of the areas I think we're considering, and we'll bring us back around and talking today about the gastrointestinal tract, is your microbiome. So in your GI tract, you have somewhere around 100 trillion cells that are composed of about, I think, 30 to 40 species of different bacteria. There is some yeast that's in the GI tract that actually is natural for it to be there. Usually you don't see a yeast-free GI tract. So there is going to be some, but not a lot you don't want. So you have all this huge environment in the gastrointestinal tract. And what we're starting to realize, and quite fascinating, is the amount of areas in medicine where this might have an application for the use of probiotics. That means giving healthy bacteria to the gastrointestinal tract, or even some different types of yeast that do not colonize in humans but can be used to treat other conditions like antibiotic diarrhea infections that can happen frequently after use of using antibiotics. One of those is known as Clostridium difficile. And so we're beginning to see a use for all these things, and even connections to diabetes, where the diets that we're actually consuming. Because here's the confusing part with diabetes. Why are we having much more of it? That's really the question. I mean, with all that keeps showing up and the therapies that exist for it, which there aren't a tremendous amount of therapies for it, than drugs and insulin and herbs and minerals and vitamins, which can definitely help, by the way, those last three. Why are we seeing more of it? And we're having a hard time explaining, well, it just can't be the fact that we're eating so much sugar that we're wearing out the pancreas. Because what kind of happens in the body, as far as we understand it, is that your glucose is stored in the liver, the fat, and the muscles. That's the main areas in the body where it's stored. And insulin, which is the hormone that comes into your pancreas, tells the liver, the fat, and the muscles to store glucose there. The main areas in the body. There's other areas in the body, the main storage sites. And what begins to take place over a period of time is that the insulin sensing, the ability for the cells in the liver, the fat, and the muscles don't sense insulin like they used to. And so the pancreas has to increase the amount of insulin it's putting out to maintain this homeostasis in the body, to maintain proper blood sugar control. Okay? But it can do it for so long to put out so much more insulin to where the pancreas begins to get literally tired and wore out, and insulin levels now are maybe either very, very high, or now they're going down to a certain level. Now glucose gets out of control, and those patients possibly might develop, increased, of course, weight gains involved in this process. They may already have high blood pressure. They may already have high cholesterol. They may be getting to have high urination. They're having trouble with their eyesight. Possibly these are just some people who've been diabetic for a while and haven't been checked out. But here's what things begin to happen. But the question gets back to what makes that signaling breakdown. That's one area way of looking at this. Well, now we're starting to see that the dietary approach is huge. And it's the fact that people are eating such high energy type foods, not good energy foods like soda pops and refined sugars like, white bread and pancakes and candy and, soda pops, to where it literally begins to affect not only the fact of how we store sugar in our body and maybe how the pancreas is putting out insulin, but it begins to infect the environment directly in the gastrointestinal tract, who's being exposed to these food products on a regular basis or through a myriad of times going on. And now we're realizing this microbiome, this other world that exists literally inside our gastrointestinal tract, is beginning to be discovered to have a hand in conditions such as obesity, in conditions such as even type 1 and type 2 diabetes. And yes, even possibly having a hand in how we developed or how we avoid developing cancer in our bodies. It's very fascinating. And like I said, there's a lot of research that's really ramping up in this direction, which is good to see. And it's to a point where it has to happen. And it's not so much that, I'm sure you're going to have products out there that, the drug companies are going to get involved in and say, well, we need to create certain type of antibiotics and we're going to patent those. These are our kinds. And so, but it's a very interesting world of using bacteria for treating gastrointestinal disease or disease that may originate in the GI tract and lead to a systemic or even an autoimmune condition. An interesting fact that I found this weekend, we talk a lot about our genetics, where we came from. And if you've never heard this before, but, chimpanzees and humans are very, very close in their DNA as far as how it's coded. In fact, I think we have like 98%. They have 98% of our genes. Pretty much, they're like us, except they're a chimpanzee, right? Within reason. Okay, I'm not discussing evolution here. I'm just saying, based on genetic coding done in humans and what's done in chimpanzees, they're very, very close together. Yet, chimpanzees don't get autoimmune diseases. They don't get things like Crohn's disease. They don't get ulcerative colitis. They don't get rheumatoid arthritis. They don't get juvenile arthritis. They don't get lupus. They don't get ulcerative colitis. You don't get these other autoimmune diseases that we see in humans, which is fascinating. It really is. So what's taking place in that direction? And probably has a lot to do with the fact of what they eat and what's probably in their gastrointestinal tract as far as bacteria. Half of your fecal matter that comes out of you, I used to think it was a third. It was updated this last week at this conference that half of what comes out of us is bacteria. It's amazing. Half of that is bacteria, not food broken down. It's bacteria. So there's constant new ones being grown and new ones dying off. And so when we start to realize this, it becomes really important to look at our overuse of antibiotics. And we're starting to really see an interest not only in fields like naturopathic medicine, which I am an ND member, but in the mainstream medicine, such as medical doctors and DOs and nurse practitioners who are now realizing that there's been an overuse of antibiotics for a long enough time that we're creating bugs that are very, very hard to kill. And it has a lot, and these are things that sometimes even harbor inside of us. And so we're seeing an uptick in infections. I mentioned this word earlier called Clostridium difficile, or C. diff for short, where that's occurring more often than it used to. It's now happening, there's a recent study that I was going to talk about today where 2/3 of patients in a certain study were able to prevent getting C. diff if they were taking probiotics while they were receiving antibiotics for an infection. And one of the doctors put up a very interesting picture, and it was the outline of a handprint on a little petri dish, and this is how you grow bacteria, that was the outline exactly of C. difficile on this petri dish from a hospital worker, just from a glove after they'd handled the patient. And I guess someone was curious, and they put it literally on a glove print, and that's how rampant it can be in hospitals. And the problem is, well, why is it rampant in hospitals? Well, it's rampant in hospitals because these are places where you see some super infections in patients where they have to be hospitalized, otherwise they're going to die if they were at home, to be treated with various courses of antibiotics, even IV antibiotics, to try and rid them of an infection that they've acquired. A lot of times on their own, not in the hospital, but a lot of times it can happen in the hospital too. These superbugs have been created from the overuse of antibiotics. We're making the bugs, in a sense, stronger. It's a pretty wild world about that. And it happens a lot more often in patients who are receiving antibiotics chronically, it means frequently, over long periods of time for urinary tract infections, for chronic sinusitis. And these are huge areas where they've been used so much, different types of antibiotics. We're starting to run out of choices. Doctors are to pick certain antibiotics to treat certain bacterial problems in patients. And so looking at, well, how else can we look at treating these things? And it's getting back to, well, how do we really affect the immune system? And this throws us back around to the huge topic of the day. We're talking about gastrointestinal health we turned into today, and various things within the gastrointestinal health that are now being linked to a variety of diseases, processes that happen in the body, or how our immune system even works. Most of our immune system is present in our gastrointestinal tract. And that's a big deal. And it's becoming a big area to actually try and treat and begin to help patients out with their gastrointestinal tract. All right, folks, I'll just pause to remind you, this is Dr. Michael Ellenburg. If you have questions or comments about your health, 522-1020, 522-1020. Give me a call here. Doing a kind of an ad-lib radio show today. Usually I have about 8 topics. I got most of those in my brain because I worked on the show last night and this morning, so some things are in my head, but my notes are not available, so it's going to be a little spread out as far as what we're talking about today, but I hope you're enjoying things so far. And again, questions, comments, give me a call at 522-1020. We've got a break coming up in about 2 minutes, so if we can't talk to you right away, we can talk to you after the break as well. So I'll continue here for the next minute and a half or so, and then we'll get ready to go to our break. So gastrointestinal health begins to become a huge place of treatment and looking at how we can enhance the environment in the gastrointestinal tract. And that area is going to be with probiotics. And there are many different products out there that do that. Bacteria, healthy bacteria, in a sense, that start to get things kind of built up in the GI tract. We get a caller online. Let's hop you on there real quick and talk with you. Go ahead. Patrick, are you there?
Yes, I'm here.
Hi there.
I had a question. Actually, you were just talking about the bugs getting stronger because they're being treated.
Right. Well, we're treating so many different infections with antibiotics that we're making bugs get resistant to antibiotics.
Right. I understand how that works, but I was wondering if there's a way, do we have a timeline until we run out of solutions? Or
no, we don't know. And what's unfortunate is this one article this morning was talking about since 1938, we've had 12 different classes of antibiotics that we've come up with, over a period of time. And only in the last 10 years, 20 years, we have 2 classes added into the use of antibiotics. So I would say, timeline, I can't on things. We're almost probably at, 15 years out. We better find some new stuff.
Oh,
It's not good. No. We'll talk more after the break of what you can use besides antibiotics for things. So, okay, thanks for the call, Patrick.
Thank you.
Don't forget what your good book says. Southern change gonna come at last. I'm your only friend, I'm not your only friend, but I'm a little glowing friend, but really I'm not actually your friend, but I am.
Hi there, folks. This is Dr. Ellenburg. Welcome back to our medical show here on Fox News Talk 1020. You can also find us on FM at simulcast at 95.5 and online at foxnewskoan.com. That's foxnewskoan.com. Questions about your health, questions about medicine, comments about medicine, they're welcome too, of course, at 522-1020, 522-1020. So if you missed the first part of our show today, it's been kind of a hodgepodge information of things. My notes got all messed up in the email transfer from my other computer, so we're kind of winging it today in a sense, but I was talking a lot about gastrointestinal health, gastrointestinal disease. What are things that we're now starting to see that may actually have an origin in our gastrointestinal tract leading to more systemic problems like cancer, for example, like diabetes, which are surprising things to find out. And our caller before the break, Patrick, there was asking about, is there a timeline? When are we going to run out of things to treat with antibiotics? And a reminder, I want to say this, and I know many, I'm sure you realize this, maybe you may not, and that is antibiotics only kill bacteria. And one of the studies that I was going to mention today was what are the top? They had the top states picked for who uses the most antibiotics. And I think the South had the highest amount. I think Kentucky had the highest amount of prescriptions written in 2010. Of course, Alaska had the least, and that's more so for the fact that we have a small population. So it's not to say that antibiotics aren't used. In the state of Alaska, they certainly are used up here as well. But it's again a reality of the overuse of these antibiotics and what begins to happen. And I mentioned before the break, that is, urinary tract infections, chronic sinus problems in general. We have a lot of people taking antibiotics for a long period of time, and we're getting more resistance from bacteria that cause those disease conditions that require the heavier use of other antibiotics, or people end up having infections that last many weeks longer than they should if we end up doing this for some time. And the question was, Patrick, are we going to run out? And the article that I'm paraphrasing here that I read this morning was, since 1938 or 1939, when antibiotics kind of showed up on the scene, till like 2000 I think, we had 12 classes of antibiotics brought forth. And in the last 10 years, we've had 2 classes of antibiotics brought forth. 2 classes, and there's been 12 total, basically, these big classes of antibiotics that are used in medicine. So what are we going to do about that? I mean, we're going to have to develop more different classes of antibiotics that kill bacteria, don't kill viruses, that kill bacteria. Or we're also going to have to definitely be looking at, which we're starting to see finally, is this a massive what's the way to say, research piling into looking at what's in the gastrointestinal tract. What are the bacteria we can identify? What are bacteria we think are involved in healthy processes, promoting the health of the gastrointestinal tract and promoting the health of the immune system? Okay? Remember, a large portion, like 75% of your immune system, is in your gastrointestinal tract. So if we're seeing a chronic problem in a patient, why not treat him with maybe probiotics along with other agents that are going to be more antibacterial if we're trying to kill bacterial infections, using it in conjunction? Or better yet, what if somebody has a really nasty infection? What if we give them enough probiotics, enough high doses in the billions and trillions of units that we actually can ramp up and support their innate? That means your own abilities to fight back with bugs with your own immune system, called innate immunity is what it's called. I think it's where we're headed to. And the other part that was important at this conference that I really picked up on, and I've heard this before, but they really drove it home well during 2 different talks, is something called biofilms. And for a long time, so the last several years, biofilms in medicine have been discussed kind of as among clinicians that, that's just some term that people who, don't talk about biofilms in your GI. What are biofilms? Well, what we're starting to see is, for example, let's pick something. Let's say candidiasis or candida. There's candida in all of us to some degree. But what we can start to see with candida, and that's, of course, that's a fungus. That's not a bacteria, but with other different types of organisms found in our GI tract, like candida or the bacteria, is they're creating a microenvironment of their own. It's like having like a community, a gated community. That's a good way of describing this. A gated community of 90 houses, right? And the gated community 90 houses are called the candida, and there's 90 different homes of candida in that gated area. Well, those homes are spraying out stuff in the environment that keeps other things from killing them off, okay? And so what we're starting to see is that bacteria or viruses or funguses in the GI tracts of humans and even in research animals can exude, can put out different substances that protect them from things trying to kill them. For example, with a bacteria, like an antibiotic. So you have these films that are literally created around these colonies of homes of bacteria in your gastrointestinal tract that are protecting themselves. And when antibiotics are actually used, the antibiotics may not be able to penetrate a lot of these biofilms, for example, with the bacteria and not kill many of them off, and therefore lead to an infection that is really hard to get rid of. For example, like Clostridium difficile or C. diff, which can happen after even receiving antibiotics. You have Clostridium difficile in a lot of us, not all of us, but in a lot of us. And with antibiotics use, you kill off the good guys and the bad guys. And with the kill off of the good guys, When things grow back, you can have a overgrowth come back of pathogenic bacteria that actually exist inside your own body. And C. difficile or C. diff have a very tough biofilm, and that's why it might require several different antibiotic regimens to kill them off. Well, now we're seeing that discussion comes up and talking about things like chronic sinusitis. Now, that's not inside your gastrointestinal tract, or is it? Well, we don't tend to think of our mouth as the beginning of our gastrointestinal tract, but it is. And that includes the inside of your nose. That includes your sinus cavities in your body because that's connected with your GI tract. So bacteria can migrate right up inside your nose, right into your sinuses from your own body, for that matter. And now the discussion is, when trying to kill these chronic infections, is the use of various different types of enzymes, mostly natural, by the way. They're not, not mean some lab, so to speak, that exist in the world that can break up those biofilms when we're trying to use other agents that might have antibacterial or antiviral activity or antifungal activity. I think we're going to see some very promising things come forth down the road here, and doctors are going to be forced, pharmaceutical companies are going to be forced to look in this direction towards these things and, develop things that they may make $1 billion off of, but actually be able to get rid of chronic infections, get to a point where we're going to be stuck trying to treat anything. But things are out there. We're just not using those things because they don't make anybody $1 billion, right? You don't hear about things like grapefruit seed extract or oregano oil or olive leaf extract or just that's just a few to name, because you can't patent those products. If you can patent them, then you can take them forth and make all kinds of money off of those things. So we don't hear about those sort of things. But we're getting to a point where we have to start including some of those things into our regimen or into our toolbox. There's a fancy word in medicine called our armamentarium. It's the medicine's toolbox of things to treat disease with, and include those into the picture, and include the use of things like antibiotics. And once again, I don't know how if you've maybe heard this show, but I've talked here on the station and a different station too for several years. I was at a conference last year that was just on probiotics, and the same discussion came up that for a lot of us as practitioners in prescribing antibiotics to our patients, prescribing probiotics to our patients, healthy bacteria, we're not giving enough high doses to actually seed and help out the gastrointestinal tract. Literally, in some conditions, they're giving patients trillions of units of probiotics, and then seeing some positive results in some very hard-to-treat gastrointestinal infections specifically. So we're gonna have to figure this out and see where this turns to, and see what it ends up with. But it's going to be very, very interesting in the end. All right, folks, this is Dr. Michael Ellenburg. It's our medical show here on Fox News Talk, 1020 AM, 95.5 FM. Questions about your health, questions about medicine, comments about medicine, they're welcome today. We've had a little glitch with my information that I usually bring along with me. It's not all here with me, so I'm having to pull from the old chest and the brain there to work, but it seems working pretty fine today. Our number here is 522-1020, 522-1020. Questions about topics or medicine, give me a call. Today's a great day for those questions. You will move forward here with my recollection of my show that's not available in front of me, and we will talk about statin drugs. So statin drugs have been out, I think they came late 80s. They came out. So what's a statin drug? A lot of times you'll hear it, well, I don't know what a statin drug is. Well, that's what treats cholesterol or high cholesterol, or trying to treat the bad cholesterol known as LDL, or a low-density lipoprotein is a long name for that. And you've heard me talk before here on the show about the importance of cholesterol, and I want to begin with that part right there, because what many of us don't realize is how important cholesterol is to our bodies. You actually need it for life. You can't live without it. Every single cell in your body has a membrane. It's a wall, and that wall is made up of cholesterol, okay? You need it to make the cell walls. You need cholesterol to make most of your sex hormones like testosterone and estrogens and progesterone. You need cholesterol to make adrenal hormones such as norepinephrine or epinephrine, also known as adrenaline and noradrenaline, the older names. You need this to make cortisol in your body. And so it's highly, highly important that we have good levels of cholesterol. And there was a doctor who presented the last day of the conference, and Dr. Stephanie Seneff, yeah, it's close. He had a lot of great data on some really good facts surrounding cholesterol and what's actually been seen in research which is, in the show I like to give you some evidence-based research, because today in medicine that's the big argument. Where's the evidence? Well, here's the evidence. And so I can't tell you what study it came from because my notes for that are in front of me today. But we can talk about, in the sense of the statin drugs, what are we seeing? And there was a long-term study done, and I want to say the patients were enrolled at age 70 and followed for 17 years. And obviously some people died during the study dates, and the point was to see what effect, if any, statin drugs had on all-cause mortality. And that means dying from anything, okay? And, of course, some of those probably were accidents, but a lot of them probably weren't. And what they found out is, as a participant in the studies, cholesterol pretty much got under, they were using European numbers, which is a 5, which is like around 180. Once it got kind of under that, it was increased. There was a massive increase for all-cause mortality in both men and women in those age groups who were taking statin drugs. Now, am I saying that statin drugs increase the risk of dying? It's possible. We can also say statin drugs decrease the risk of dying to some degree because they're working on treating cholesterol problems such as LDL. Not total cholesterol. I'm talking about LDL cholesterol, and there are certain subtypes of LDL cholesterol, known as some small LDL, for example, that can enter your arteries from injuries taking place inside your body and can lead to calcifications and plaque and lead to further disease. And we do know that statins seem to have some type of a hand in that. But the data is beginning to point to the fact that we might actually be seeing an increase in certain types of cardiovascular disease disorders in relation to statin drug use, things like Lipitor, things like Zocor, also known as Simvastatin, or Pravachol, known as Pravastatin, these drugs that are inhibiting the ability of your body to make cholesterol to a large degree. And if we're going to decrease the amount of cholesterol the body's making, we're seeing, and it's not the first study to see that I mentioned. We've also seen the study before where basically under 160, people had increased risk of cancer and infectious disease rates in those groups whose cholesterol is under 160. And the reality is, we're now getting to see also in patients that we have an uptick possibly of congestive heart failure in patients who are on statin drugs long term. And one of the questions is, well, why would that even happen? Why would we even see that? Well, the body is an amazing, amazing machine that we know a lot about, but there's a lot more we don't know about the body. But one area we do know is when it comes to statin drugs is that their mechanism of action, that they're kind of been put upon to decrease cholesterol levels in the body, is trying to decrease the ability for your body to make cholesterol through a little known process, an enzyme. And enzymes operate your whole system in a sense and make things happen. It's a reaction stealing. It makes things happen faster. But you can inhibit certain enzymes, and there's a very fancy term called HMG-CoA reductase, which is an enzyme that helps make cholesterol in the body. Well, that same enzyme is also involved in making what's known as coenzyme Q10 in the body, or CoQ10, which is a supplement that's been on the market for a long time. And CoQ10 is highly, highly found in areas where you have a high metabolic rate. That means in areas where you have a high cell turnover and for example, certain organs, they're doing a lot of work for your entire life. Two of those ones being your liver and also in your heart. And this is why patients who might be on statin drugs for a long time will end up having liver enzymes measured to make sure they're not elevated. And it's also, while patients are asked frequently, how are you feeling? Do you have any fatigue? Do you have any muscle weakness? Because CoQ10 is also found in muscles at very, very, very high concentrations, like the heart. And there was a long-term study that looked at the use of statin drugs in populations, and we've actually seen an increase in congestive heart failure over the last 20 years. I don't believe that was in everybody who was taking a statin drug, but yet it's interesting we're seeing more of it, because one area where it seems that medicine has done a good job attempting to decrease the death rate is from cardiovascular disease over time. It may seem surprising to say that because you're like, well, I don't know if I believe that. Well, the data is out there. There's actually been some major changes in the amount of heart disease in comparison to 50 years ago. We've gotten somewhere. It still is a major killer of people, unfortunately, but it's not as bad as it quite was. It's still bad, though. But what if statin drugs are increasing our risk of developing congestive heart failure? it make more sense and start looking at using different drugs that will not increase someone's risk of death or make their condition worse, because congestive heart failure happens on its own outside of statin drugs, and at times patients will put on statin drugs to keep cholesterol levels low because they have a myriad of symptoms. Maybe they have congestive heart failure along with diabetes, for example, and they have high cholesterol. So the doctor is doing the right thing. We'll say, well, we're going to treat that cholesterol. We'll put on a statin drug. And so we're following a good medical protocol there. But at the same time, is maybe that drug long term is going to affect their heart function. And it probably will long term. So, if you take statin drugs, you need to be informed of all that's available out there and what is the information about that. And that's what the point of me telling you all this information is. I'm not saying to go take your statin drug and throw it in the garbage. You may want to have a healthy conversation with your provider as to, are your numbers or were your numbers before you were put on statin drugs really that bad? And the second discussion you want to have is, if you were put on a statin drug as a preventive measure so you won't get high cholesterol, I would suggest that was a bad idea, okay, based on what I'm seeing in the research coming out. Research, not some harebrained thing off the top of my head. I'm talking about research being done out there and being seen in the data, okay? But a lot of what gets to you, if you don't know this by now, is filtered out. And even a lot of journals don't put articles in that might talk bad about some competitor's product that's advertised on page 249, for example. Okay? It won't be in that journal. It may not be another journal for that matter as well. It's a big source of income for medical journals these days, is drug advertisements in the magazine itself. Okay? So we have a lot of problems around the use of that. And next week we're going to go over statin drugs again. I'll be reading off those studies and in more detail, very clear, because some got a little muddled around, I'm sure, in my brain from this morning, but most of it was there. So I hope you consider that and learn more about that as well. We have about 7 minutes left in today's show, roughly 6-7 minutes. If you do have questions about your health, it's a live call medical show. Your calls are welcomed. That's 522-1020. It's 522-1020. Questions about the health, comments about medicine, give me a call. And we'll think about a few more things to talk to you about here. Another study I wanted to mention as well was one on vitamin D that we came across in, not so much a study but a comment on that, and that is cholesterol in the body is used to help make vitamin D. And there was a study that came out, no, that was on Fish Oil, that one, but not a study, but more or less a comment that if you're reducing cholesterol levels too low, the ability to make your own vitamin D in your own skin will be diminished. And remember, we live in Alaska, right? And in the winter, it's dark. Right now, the sun's going to go down in about an hour and a half, here in the Anchorage area at least. And you're not getting any vitamin D from the sun this time of the year unless you go somewhere warm, towards the south, next to the equator, basically. And it's important to realize that having good vitamin D levels can affect your health and can affect getting a common cold, regardless of the studies that came out recently saying, one study came out saying, well, it is no good for the common cold. Well, people probably weren't taking enough in the first place, or maybe there's a point in time, if you have certain levels of vitamin D, you don't need any more. And I would say it's certainly possible. That makes some sense. But get a blood test done. Smartest thing you can do on your vitamin D levels. And obviously, if you have a 5-year-old kid, that's not going to be the case. But at least make sure your child's taking the minimum dose daily, which is 400 international units. At least give them that a day. That'd be okay. It won't make them toxic. But when it comes to your health as an adult, getting a blood test done makes more sense, because then you can properly get advice from your provider to say, how much vitamin D should I be taking? And you'll have some evidence to say, okay, where am I at on this test? And the test is a big range. It goes from 20 to 100. It probably should be a lot more narrow range on vitamin D, and eventually we're probably going to get there. I don't know when. Eventually we'll get there. Definitely consider that part of the process, and definitely with the cold flu season, take some extra vitamin D, take extra vitamin C. These things actually do help. They do. Okay, and the data does exist out there that shows that they do. Okay, if you want your flu shot, go for it. I don't recommend those myself, but that's what you want to do on your end of things. So things to have to avoid the flu for the flu season. And one article I want to bring up again, which I think is we're talking about, this is on my mind, I saw a reference to it this morning, is people who frequently get gout. And there was a study that came out looking at the prevalence of gout, that means how common gout happens, and they were measuring lead levels in these patients who are getting gout. And a lot of you think, well, if I don't work out in the occupational world in the sense of the industry, how would I ever be exposed to lead? Well, we're being exposed to lead from water, or maybe exposed to lead from your house you live in. It can be in different products. It's quite prevalent in the environment. And I would say that of the most common heavy metals that we test for in patients, that we see in patients more often than not, is lead, mercury, cadmium, and arsenic, and aluminum. I see those in almost every person I test. I mean, as my son, he's 12 now, but I had him tested when he was 10, and the test was just a urine test. You pee in a cup and you send it into the lab and look for what comes out of you, basically. And the metal picture was like 20 metals, and it's amazing even for a child who's been on this planet for at the time only 10 years, what was in him, right? 10 years on the planet, and I didn't work around a smelt factory. I didn't work in a zinc mine. I've been a doctor. Is why he's been alive. And I haven't been exposed to any of these things and get inside my own sin because the world that he lives in. Okay? We're talking Washington State, lived in Seattle, and moved back to Alaska. So, and living in Anchorage. So we're not living out in some area where we're, drinking the water out of some ancient well, for example. So these things are out there in the environment. And what we found what they found in this particular study is that patients who got gout frequently had higher lead levels in their body. Now, we don't know of a causative mechanism of suggesting that how lead is going to increase one's risk of gout, but it may have a hand in it. We know that lead is stored in the bone in humans typically and in the brain, and could lead to an increased risk of gout. It might make some sense. Or it's somehow increasing the amount of that uric acid, and that's what causes gout, specifically is uric acid crystals, and those little tophi crystals that form in big joints. The big toe, for example, is a common area, wrist or even the finger sometimes, that may have a hand in increasing that production of that in your body somehow. So if you get gout on a regular frequently, or get gout a couple times a year or once a year, consider being tested for your lead levels. And if you're taking something, I know somebody, for example, who takes allopurinol, and they take it every single day because they've gotten so much gout. They take it every single day because they don't want to change their diet, which is a major factor upon how one gets how one gets gout. But they may actually have high lead levels that they've been exposed to, and that's increasing their outbreaks of gout. It's a simple blood test. If you do have it in you and it's in your blood, it's what's in that blood sample is only what you've been exposed to in the last 45 to 60 days. Otherwise, lead is stored in the bones. Check the bones. That requires bone marrow biopsy, or requires some type of a provocation test where patients are giving chelating agents to help their body assist in dumping out heavy metals. Okay? That's the best way to test for that, in my opinion, is this last one. Giving an agent to provoke the system to dump heavy metals and then seeing what comes out of folks. So remember that about lead. And yes, it is a big deal. And definitely at some point in time, I think anybody who's been on the planet longer than 30 years could probably do well to have a heavy metal test done. And they do exist. More information about those tests, a good site online is doctorsdata.com, doctorsdata.com. Well, folks, thanks for listening today. And thanks to the caller today, Patrick. Great question to ask about antibiotic use in this country. And as usual, I'm here on Mondays from 2 to 3 p.m. And during the week, you'll find me at the Ellenburg Center. Our phone number there is 563-2366. Our website address is drellenburg.com. That's Ellenburg with you. Everybody have a great week, and we'll be back here next Monday. Oh, and have a great Thanksgiving. I almost forgot about that. Everybody, take care and have a safe one. Bye-bye.
Big round people in a cool little square. Or you can cut it with a boat or a plane. Man, it's gonna take a new train. You'll be leaving on a new train, far away from this world of pain. And when you look out your window, you'll see your home, your baby, and your family.